Good afternoon, everybody. Thank you for being again tonight with us in this Meet the Expert webinar organized by the WPA in collaboration with the MSc Clinical Mental Health and the Institute of Neuropsychiatry of Samara University. We have a very distinct colleague tonight, but first of all, I will give the floor to the WPA president, Afzal Zaved, to open tonight's session. Afzal.
Well, thank you very much. Good evening and good afternoon. I mean, what a player that this particular session is being attended, and our speaker is such a dynamic, such a big leader in the field of psychiatry. And I must say that these webinars are very, very important and popular webinars being supported by two universities, one in Greece and one in Russia. But more importantly, this is providing a lot of new insights and understanding to our trainees and to our young professionals. I must thank the honorable speaker, the organizers, and the participants for attending this meeting. I'm sure that Professor Fountoulakis and his team will continue working hard and making education really at the doorstep. Thank you very much, Professor Fountoulakis, and I look forward listening to Professor Nemerov.
Thank you. Thank you, Afzal, for your kind words and the introduction for tonight. And it's a real honor and pleasure to have with us Professor Charles Nemerov, who is very well known, but still I need to introduce him. He is professor and chair of the Department of Psychiatry and Behavioral Sciences at the Dell Medical School at the University of Texas at Austin. He also directs the Institute of Early Life Adversity Research within the Department of Psychiatry as part of the Mulva Clinic for the Neurosciences. Prior to joining the Dell, Dr. Nemerov was chair of the Department of Psychiatry and Behavioral Sciences and clinical director of the Center of Aging at the University of Miami Miller School of Medicine in Miami, Florida. He received his medical degree and doctorate degrees in neurology from the University of North Carolina School of Medicine, has received a number of research and education awards, so many we cannot really name them, including the Mrazek Award in Psychiatric Pharmacogenomics, Camp Award in Psychobiology, the Samuel Hibbs Award, Research Mentoring Award, Judson Marmor Award at the Westermark Award for the American Psychiatric Association, the Mood Disorders Award, Bovis Award, and Dean Award from the ACP, and the Julius Axelrod Award for Mentoring from the ACNP. Professor Nemerov, it's a great pleasure and honor to have you with us tonight. The floor is yours.
So let me just thank my hosts for inviting me to be with you. It's quite early here in Texas, so it's noontime, and I know many of you are in Europe, so it's evening. And I'm going to talk to you today about a subject that is very controversial at this time, and that is the use of laboratory testing to predict antidepressant response. This is an area, as you'll see, that has great promise, but also great controversy. These are my financial disclosures. All of my research is supported by the National Institutes of Health. I have consulted to a number of companies over the last year. As you can see here, I serve on a number of nonprofit advisory boards, including the Brain and Behavioral Health Foundation. I'm the president of the Anxiety and Depression Association of America. But all of my research is supported by the National Institutes of Health. And I will be describing work today that involves many of my collaborators from institutions which I was previously affiliated. And so you'll be seeing those, these individuals as I go through this presentation. Well, let's start off with what many view as the Bible, the Diagnostic and Statistical Manual of Mental Disorders, DSM, published by the American Psychiatric Association. And this is what we use to make our psychiatric diagnoses. It obviously is closely related to ICD diagnoses as well. And you can see that we started at DSM 2 here, which was a very, very small volume. In 1980, we had DSM 3, then DSM 3R, then DSM 4 and 4R, and now we have DSM 5, and we will be coming out with a modification. There are no laboratory tests of any kind in DSM 5 that suggests that they can be accurate in making the diagnosis of any psychiatric disorder, nor are there any tests that are claimed in DSM 5 to predict treatment response. Now, we all know what the diagnostic criteria are for major depression, as shown here. One has to have 5 of 9 of these symptoms. And a enterprising young psychiatrist made the calculation that there are more than 20,000 combination of symptoms listed here that could comprise the diagnosis of major depression. And all of us who are clinically focused on major depression know that this diagnostic category is incredibly heterogeneous, and that there are patients that literally have virtually no symptoms in common that fall under the umbrella of major depression. And this is just an example of the kinds of heterogeneity I'm talking about. So if we had laboratory tests that could help us distinguish between the many phases of major depression, which is one of the goals of personalized medicine in psychiatry, that would be very helpful. I'll just remind you that precision medicine or personalized medicine has 2 major goals. One is to more clearly define diagnosis and be able to identify subtypes of depression. And then secondly, more relevant to what we will talk about today, is the issue of being able to predict with a reasonable degree of certainty a given treatment for a particular patient. So this is the essence of personalized medicine. And you can see here that there are a number of factors that we're outlining that you should think about when diagnosing and treating major depression. First, there are many combination of symptoms. You could see here just a few of these, both in terms of the 5 of 9 symptoms required and all the different combinations. You all know that there are subtypes of major depression, ranging from melancholia to atypical depression to psychotic depression. Let's not forget bipolar depression. And we also know that there's a tremendous amount of comorbidity that occurs in patients with major depression. All of these factors render the choice of treatment somewhat problematic, as I'm sure you are aware. So there is the model that you should think about when you're seeing a patient with major depression, and you're thinking to yourself, where do they fall along the spectrum? And obviously, the most important point is to distinguish patients who have unipolar depression compared to those with either bipolar 1 or bipolar 2 disorder. There are these other entities that you should think about. One is dysthymia, which has been renamed in DSM-5 as a persistent depressive syndrome. Often it's combined with major depression and what we used to call chronic depression. Now, this is the comorbidity issue I alluded to earlier. Very high rates of comorbidity of several disorders with major depression, making the choice of treatment and the diagnosis more problematic, including PTSD, social anxiety disorder, OCD, GAD, and panic disorder. So you all have seen this graph many times. This is from David Kupfer, who was at the University of Pittsburgh. And as you can see, it summarizes treatment of depression. And patients come to us here where they fulfill criteria for the depressive syndrome. We treat them as aggressively as possible, and we want to get them into remission, which is the gold standard the gold standard for a goal of treatment of depression, and then we want to keep them well. And in order to do that, we of course have to measure a depression severity, either using a self-rating scale like the Beck Depression Inventory, or using an observer-rated inventory. And in most clinical studies, either the Hamilton Depression Rating Scale is used, in which a HAM-D score of less than 7 is consistent with remission, or the MADRS, in which scores less than 10 have been validated for remission. If we don't get patients well, that is into remission, all sorts of bad consequences occur. Higher risk of relapse. The longer they're depressed, the more likely they are to become treatment resistant. They obviously have continued psychiatric morbidity. They have decreased occupational functioning. They increase medical care utilization. And obviously, what we worry about the most is that they are at more increased risk for suicide, alcohol, and substance abuse. It's not generally appreciated. Depression is an independent risk factor for developing a number of severe medical disorders, including myocardial infarction, stroke, certain forms of cancer, type 2 diabetes, and other disorders. So these are all the good reasons why it's important for us to be able to predict treatment response in depression. Now, it's pretty clear that these subtypes of depression, particularly atypical depression and psychotic depression, respond differentially to treatment. And in the end, we will need predictors of each of these subtypes of depression. So we have a number of possibilities in treating depressed patients. There are a number of evidence-based psychotherapies, as you're all aware, namely cognitive behavior therapy, interpersonal psychotherapy. There's even evidence that brief psychodynamically based psychotherapy may be effective in treating depression. We also have other non-pharmacological effective treatments, including electroconvulsive therapy, transcranial magnetic stimulation, vagal nerve stimulation, and light therapy for seasonal affective disorder. Deep brain stimulation is still an experimental treatment, not yet approved by either EMA or the FDA. And then we have all the medications. And we have, fortunately, a large menu of antidepressants to choose from in treating our patients. Unfortunately, what we learned in the seminal study from my colleague in Dallas, Meduka Trivedi, the STAR-D study, is that patients don't do as well with monotherapy as we thought they did. So this was the largest effectiveness trial ever done, in which 2,400 patients were treated with citalopram, open label, a standard SSRI. And when they didn't respond, they were randomized to subsequent treatments, to bupropion, to CBT, to sertraline or venlafaxine, or they were augmented with other treatments. And so we learned a lot from this study, but it was mostly bad news. What we learned here was that only a third of the 2,800 patients that received citalopram up to 40 milligrams a day attained remission. Only 40%, which is really 33%, which is much smaller than we thought in this study, which was an open study. So that was a awakening for us that 67% of the patients treated with citalopram did not attain remission. So you could see here in the STAR-D results that if you kept treating patients with other treatments after they failed citalopram, you would bring some patients into remission. So the addition of bupropion and buspirone brought about 30% of those non-citalopram responders into remission. You could see that those that were switched to venlafaxine, about 25% responded, and so on and so forth. The problem is, as additional treatments were added, the patients became less and less able to tolerate the treatments due to side effects. And so what we really need are predictors of antidepressant response. And this is particularly an issue in patients with anxious depression. They have the lowest rate by far of antidepressant response, certainly in terms of monotherapy and augmentation. The other problem that we're well aware of is another predictor of poor response to antidepressants is childhood maltreatment. And a history of childhood maltreatment results in a poorer course of illness, as shown in this meta-analysis from the Institute of Psychiatry in London, and a poorer treatment response. So what you're looking at here is treatment outcome. The solid line in the middle of the page is no effect. The dotted line is a summation of all of the trials that have shown that depressed patients with a history of childhood maltreatment have a poorer response in general to psychotherapy, pharmacotherapy, and the combination of the two. So the heart of this presentation does not focus on the question of can biological markers help in the diagnosis of major depression or its subtypes. It focuses on this question. When a patient is sitting in your office and you've made the diagnosis of major depression, you've done all the right things. You've eliminated medical causes of depression. You've done the appropriate laboratory screening, and the patient's sitting in front of you, and you're trying to decide, are you going to prescribe an SSRI, an SNRI, another atypical antidepressant? Or are you going to refer the patient for psychotherapy? Or are you going to use TMS? All of us who are experienced clinicians believe we know what the best treatment is for a given patient. But the fact of the matter is, the data doesn't support that at all. The fact of the matter is, we're not any better than chance at predicting what the best treatment is. So this leads to the question of personalized medicine, which is a medical model that emphasizes the customization of healthcare tailored to individual patients. And this largely has involved research into genomics, which we'll talk about quite a bit. So at the top part of this slide, you can see that this is what we currently do. Patients come to us and they're heterogeneous. You know, with the exception of psychotic depression, which we know requires a combination of an antipsychotic and an antidepressant. and with the possible exception of atypical depression, which responds better to monoamine oxidase inhibitors than newer agents, by and large, we are conducting trial and error. And when we treat these patients, largely with an SSRI, in the top part of the slide, you could see some have a great effect in blue, and others have a poor effect or no effect at all. So what we want to do is to move here to precision psychiatry, where some laboratory tests, genomics, brain imaging, EEG perhaps, will predict who will have a great response to this treatment and who will not. So this all begins the story with genomics. And all of you know that we all learned this in college and high school, that DNA is transcribed to RNA, and RNA is translated, leaves the nucleus message RNA, and then on the ribosome, it is translated into protein. And the human genome was sequenced, as you know, by two rival groups many years ago, and this is what it looks like. It's not very exciting. There are only 4 letters in the alphabet, as you all know, and you're looking at them here, C, A, T, and G. Those are the legal tender of DNA, and all of us have the same DNA sequence, with the exception of some mutations. And what you're looking at here are what are called single nucleotide polymorphisms, or SNPs. So we have about a 99% homology of DNA among all of us. And these single nucleotide polymorphisms are what distinguish us from each other. And there's several million of them in the human genome. And they must be important for something, which I'm going to try to describe to you in a minute. So what you're looking at here is the triplet code, which you know codes for amino acids. So the top shows a particular individual. Remember, we all inherit our genome from our parents, and that once we inherit it, it's immutable. So the structure of DNA does not change. Gene expression can change, and we could talk about that if we have time, but the structure of your genome doesn't change. And what you're looking at here are, in person 2 and person 3, you're looking at mutations. So this adenine has been mutated to a guanine, but the triplet code, even though it's changed, still codes for the same amino acid. And that's true of a lot of these variations. They don't change the protein that the gene is coding for. But in this third person, the guanine has been replaced by an adenine, and you could see that now the amino acid that's coded for is not arginine but lysine, and that can result in a change in the protein that's coded for and in the structure of the protein, which could be a receptor, it could be a transporter, it could be an enzyme. So all of pharmacokinetics is fundamentally summarized on this slide. So when you administer a drug to a patient, there are only a few things that will fundamentally affect how that drug works in a given patient. Obviously, the dose, and the question is, what is the blood and brain concentration of the drug that you have prescribed? What will it be attained in a given patient? And that's called pharmacokinetics. And then the second potential place where things could be different from individual to individual is in the mechanism of action, the site of action of the drug, and that's called pharmacodynamics. And so the notion has been introduced that mutations in genes that control the metabolism of antidepressants might be able to predict not only efficacy in a given patient, but side effect profile. And then more importantly, perhaps, the notion has been put forward that mutations in genes that are encode for the targets of our antidepressants, like the serotonin transporter or the norepinephrine transporter or the serotonin receptors, those variations in a given individual might predict treatment response. Now, for certain disorders like diabetes, we don't need to have these kinds of tests. And this is prescribing data. And what it shows you is that more than 75% of patients that are diagnosed with diabetes are prescribed metformin. That's this green line. Well, you don't need to have a genetic test in order to tell you to prescribe metformin because it works in the vast majority of patients. Here is analogous data for the treatment of depression. And you can see there's no winner here. So some of your favorite antidepressants are in the hit parade: citalopram, sertraline, bupropion, escitalopram, fluoxetine, but there isn't an acclaimed winner, meaning we don't know what the best first choice antidepressant is for a given patient. And yet we're stuck with the fact that only 28% of patients in the STAR-D trial attained remission using the HAM-D scale. So let's talk about the metabolism side first. And as you know, some people, because of the number of cytochrome P450 genes that they have, some people are extremely rapid metabolizers. The patients who you're treating with a high dose of an antidepressant, and they say to you, I don't even feel like I'm taking anything. And then there are the extensive metabolizers, intermediate metabolizers, and poor metabolizers. So keep that in mind when I talk about the cytochrome P450 system. So all of these commercially available laboratory tests have sprung up with the claim that they can predict antidepressant response and side effects. And I've taken these next several slides right out of the website for one of these manufacturers. So, first in terms of pharmacokinetics, the claim is that if you measure the genetic variations in the cytochrome P450 isoenzymes, that you can predict with a reasonable degree of certainty what dose the patient should be on, whether it should be a low dose or a high dose, whether you should increase the dose or decrease the dose. Now, this strategy worked in other branches of medicine. There's a paper published in the New England Journal of Medicine about the drug clopidogrel, which is a antiplatelet drug for treating people post-myocardial infarction. And this was a really cool study that spurned further interest into pharmacogenomics. They took patients who were post-myocardial infarction, 1,477 of them, and compared them to 162 healthy subjects. And what they discovered was that if they genotyped the cytochrome P2C19 gene, that they could identify individuals that would end up with lower plasma levels of clopidogrel, and more importantly, that resulted in adverse cardiac events. So this suggested that among persons treated with clopidogrel, carriers of this reduced function cytochrome P450 gene ended up having lower levels of the drug you're prescribing and higher rates of adverse cardiac events. This field has been probably more successful than any other in oncology. And in oncology, these gene variants have not only predicted risk for breast cancer, as in the BRCA1 and BRCA2 genes, but it's actually predicted a treatment response. And this is a list of the agents, should you receive tamoxifen or not if you have breast cancer? Will you respond to one of the monoclonal antibodies? And this has also been found true in lung cancer. But in psychiatry, the claims are largely been focused on the pharmacodynamic aspects of pharmacogenomics. Namely, these commercially available assays have claimed that genetic variants in the serotonin transporter can tell you whether or not you should prescribe SSRIs or SNRIs. And further, they claim that other genetic variants like the calcium channel can tell you about whether you ought to prescribe atypical antipsychotics or mood stabilizers. And this is the kind of data that is presented, that, if you have this particular variant of the serotonin, a 2A receptor, then you would have an increased likelihood of response to citalopram. And if you have the LL genotype of the serotonin transporter, that you will have a faster response to fluoxetine or fluvoxamine. That looks pretty impressive. And then patients are given reports like this, in which patients come to me and they say, Dr. Nemeroff, I got this genetic test from my family doctor, and it says that you prescribed the red stop sign, that you gave me a drug that I shouldn't be prescribed. It could be dangerous. And I say, well, I don't think there's very much evidence that that's the case. And sometimes patients who receive these tests will actually stop taking their medication even when they're doing well. So these websites have gotten completely out of hand. If you look here, this is directed to patients, where it fundamentally says, we can guide you to get the best treatment for depression, anxiety, OCD, ADD, bipolar disorder, PTSD, autism, schizophrenia, chronic pain, and substance abuse. This quick and pain-free test can help your clinician work with you to build a more personalized, effective treatment plan. So in my role as the chair of the American Psychiatric Association work group for novel treatments and biomarkers, we reviewed the entire world's literature and published this paper in 2018, where we fundamentally concluded there is insufficient data to support the widespread use of combinatorial pharmacogenetic testing in clinical practice. Well, after the publication of that report, one of the companies published this announcement at the APA. They said GeneSight demonstrated statistically significant improvement in the gold standard clinical outcomes of remission and response. Wow, that sounds pretty impressive. And here's the study that was published in the Journal of Psychiatric Research. It's called the GUIDED study, a large patient and rater-blinded randomized controlled study. Let's look at this. 1,167 patients that were diagnosed with major depression were randomized to treatment as usual or a pharmacogenomics guided intervention arm. And so the primary outcome measure was the HAM-D score at week 8. Well, what did they find? At week 8, symptom improvement for guided care was not significantly different than treatment as usual. There's no difference there whatsoever. This study also had inordinately low remission rates, 15% versus 10%. Pharmacogenomic testing did not improve mean symptoms. Now, this group has gone on to publish multiple secondary analyses trying to claim that there was effect. But as all of you know, if you fail your primary outcome measure, secondary analyses have no value whatsoever. Here's a second study done at a pretty good place, Massachusetts General Hospital in Boston. Used the same commercial assay that was used in the previous study. And this was a pretty large study of 304 patients, 150 per group, randomized to pharmacogenomic testing or treatment as usual. And you see the results at week 8. There was no significant differences between the two groups at all. And they conclude that pharmacogenomic testing of pharmacokinetic and pharmacodynamic variants was not associated with improvement in the primary outcome measure. A third study, I just put this in to give this talk to all of you. Very important third study just published this past week in the Orange Journal, the Journal of the American Academy of Child and Adolescent Psychiatry. This was a study of 176 adolescents. There were no differences between the gene-guided therapy and treatment as usual at 8 weeks or at 6 months for symptom improvement. And in none of these 3 studies did the cytochrome P450 isoenzymes predict any side effect burden, which is actually a bit surprising. This was the study I just showed you, the consort diagram showing how the patients were randomized and what the ultimate outcome was. A very, very good study, as you can see here, and there's just no difference at all in any of the outcome measures, which is summarized on this slide. And if you look at remission and response using the Child Depression Rating Scale, no differences at all. So what's the problem here? Well, let's start with the fact that most of the published literature are sponsored by the commercial suppliers themselves. The studies of a short duration, with the exception of the 3 studies I showed you, they're relatively small samples, mostly not blinded. And as I mentioned earlier, remission rates were quite low. So there's been a lot of commentary about this. This is from the Harvard group, which fundamentally stated in JAMA Psychiatry that the desire to discover biological tests to guide treatment is sincere and studies should continue. But the claims on company websites may be good marketing, but they're not balanced. And the time-pressured clinician or uninformed consumer, often in distress, may be especially vulnerable to the pitch. So we do have a goal of useful biological tests to assist clinician decision-making in psychiatry, but the time is not now. And then the FDA, very remarkably, has weighed in on this as well. So Janet Woodcock is as of last week, was the interim director of the Food and Drug Administration. Rob Califf of Duke has just been confirmed by the Senate, will be taking her place. So they weighed in on this, speaking to the use of genetic tests to predict treatment response in a variety of disorders. And they say, we are aware of genetic tests that claim results that can be used by physicians to identify which antidepressant medication would have increased effectiveness or side effects compared to other antidepressants. However, the relationship between DNA variations and effectiveness of antidepressants has never been established, and the FDA is aware that healthcare providers have made changes in patients' medication based on these results that could possibly lead to patient harm. So in July of 2020, they came to a final conclusion for Medicare patients, those who are 65 and over, saying there's insufficient data to support coverage of these tests. And then they go on to talk about this in much more detail. That fundamentally the evidence suggests that there is no current test available that will predict the best antidepressant for a given patient. Now, I'm going to show you in the time I have remaining sort of some bright spots about the future. So this is a study that we did in never treated depressed patients. So these were adults aged 18 to 65 years of age. This was funded by the National Institute of Mental Health. And we randomized patients to escitalopram, duloxetine, or CBT, 12 weeks of treatment. 344 patients, and fundamentally, duloxetine resulted in a 55% remission rate, escitalopram 47%, CBT 42%. Why was the outcome better? First, these were never treated depressed patients. And secondly, this was a 12-week trial, not an 8-week trial. There are the results. You see that duloxetine in red triangles, slightly numerically better than escitalopram in blue, and then CBT in green. But very high remission rates, much better than we saw in STAR-D. Now, we wanted to ask the question, is there a relationship between occupancy of the serotonin transporter and prediction of treatment response? If SSRIs really work by blocking the serotonin and norepinephrine transporters, and you could see from this slide that others have shown very high rates of serotonin transporter occupancy after treatment with citalopram, fluoxetine, sertraline, or venlafaxine. So we decided that we would do a study in which we could measure serotonin transporter occupancy. We could not use this PET method because it would be too expensive in a large number of subjects, but you could see in this PET study, as the serum paroxetine concentration increases, it competes with the radioligand binding the serotonin transporter, shown in red on the left-hand image. And then after treatment with paroxetine, you can see there's no longer any binding because paroxetine is occupying the transporter. So we developed a in vitro method, so-called ex vivo, in which we took blood samples, we transfected human embryonic kidney cells with the serotonin or norepinephrine transporters, and then we incubated the patient's samples in this tissue culture. And we found the same relationship between the plasma concentrations of the SSRI and binding to the transporter with the radioligand. Well, let me shock all of you against everything that we all believe in about the mechanism of action of antidepressants. What you're looking at here is the serotonin transporter. On the left is the escitalopram data. So we have escitalopram non-responders on the left, responders, and then on the right, remitters. And on the y-axis is the percent occupancy of the serotonin transporter. And guess what? There's no relationship between serotonin transporter occupancy and antidepressant response at all. On the right side is the same data with duloxetine, which is also an SSRI, and you could see no relationship at all. Look, there are patients who didn't respond at all to duloxetine that had 90% occupancy of the serotonin transporter, and the same with escitalopram. Here's the norepinephrine transporter data related to duloxetine. Obviously, on the left, escitalopram doesn't occupy that transporter. Look, there's no effect here. There's no difference in occupancy between the non-responders, the responders, or the remitters. We need to rethink how these drugs work. So in the last several minutes, I'm going to talk to you now about some promising findings, none of which are contained at all in any of the commercially available assays. So this is a study I did in Japan. You can see I'm the only non-Japanese person, author of this paper, where we were able to show that, that we could predict a favorable response to the SNRI milnacipran if we looked at the norepinephrine transporter genetic polymorphisms. So one of the variants in blue showed a poor response to milnacipran compared to the other two variants. And that study was confirmed a few years ago at the University of Pittsburgh, showing that in geriatric depression, variants of the norepinephrine transporter predict venlafaxine treatment response. And I'll just show you that data. So these are big differences in remission, 73% in one of the variants versus 47% in another. These are the kind of findings that you could begin to think could have clinical utility. We did a study in the STAR-D population, and we showed that one of the components of the corticotropin releasing factor system, the CRH binding protein, actually predicted treatment response. We went ahead and replicated that in another sample, a study we did in Australia, in the United States, called the iSpot sample, which again showed that that gene variant helped predict treatment response to citalopram, sertraline, and venlafaxine. Now, I'm going to finish the presentation by talking about other non-genomic predictors of response. One is brain imaging. The problem with brain imaging responses is that it's relatively expensive to do functional magnetic resonance imaging. This was from our study I just showed you in never treated depressed patients. And we were able to show that using a metric of functional connectivity, we're able to very clearly distinguish cognitive behavior therapy responders from response to duloxetine or escitalopram. So these are big differences that could have clinical utility. The problem is that fMRI is expensive and it's probably not going to be widely applicable. But EEG, on the other hand, is something that can be relatively easily done. And so there have been a couple of investigations looking at EEG as a baseline, as a potential predictor of treatment response. So we originally reviewed the literature in 2019, and we concluded that it's not ready for prime time. The data just wasn't there. And we were very clear about that. We said it's not clinically reliable at the current time. But then two studies appeared, one called the EMBARK study, which were 300 patients that were randomized to sertraline versus placebo. So you can see in this study, patients were randomized, 150 to placebo and about 150 to sertraline. And what they reported was that EEG demonstrated quite significant utility at the individual patient level for predicting treatment response to sertraline, at least versus placebo. Of course, what we don't know is whether they may have responded to other antidepressants. Finally, we have no data on prediction of augmentation. So not only do we have no data related to treatment response to one or another evidence-based treatment for depression, there are all these augmenting agents. And when you have a patient who has a partial response to an antidepressant. And you could add any of these treatments that are all evidence-based, atypical antipsychotics, CBT, lithium, pramipexole, thyroid hormone. There's not a single paper in the literature on prediction of response. I've left a little time for questions, and I'll look forward to seeing them in the chat. I see there already is a question, but let me turn it back to our moderator.
Well, thank you, Professor Nemerov. That was a very comprehensive and impressive lecture. Thank you. There is one one question by Professor Smirnova. Dear Professor Nemerov, many thanks for your lecture. Is there any pharmacogenetics-focused international world consortium like the Schizophrenia Genetics Consortium, which precisely studies the predictors of pharmaceutical agents' response? Centers of personalized psychiatry might join this initiative and contribute with the data and biomaterial taken from the national samples. So is there any consortium?
So there is a psychiatric genomics consortium. And what they've done is collected large samples, like from the UK Biobank. And I'm really glad someone asked this question. And Dr. Smirnova, who I've not seen in a long time, actually asked that question. So I'm delighted to answer that and actually to see her on the screen. So let me say that the biggest problem with these studies has been the level of phenotyping. So one of the problems with the UK Biobank data is that the phenotyping is extremely crude. So if you are basing the diagnosis simply on the fact that the word depression appears in the EMR, in the electronic medical record, you're going to end up with a lot of garbage in the database. And no matter how refined your genetic testing is, if you don't do deep phenotyping, you're not going to end up with the right answer. So the criticism I have of the large-scale studies that have been done, not all, but most, is that they have not characterized the patients terribly well. They don't distinguish atypical depression from psychotic depression, et cetera, et cetera. Now, the GWAS studies have done a little better in doing that, and the GWAS studies have allowed us to come up with polygenic risk scores for depression and schizophrenia and bipolar disorder. And the larger the studies, the better those scores are. The only big data set to answer your question would probably be in lithium response in bipolar disorder. And there, the data looks pretty good in terms of a polygenic risk score, which of course is much more sophisticated than one genetic variant or another. Remember that the commercially available assays are limited by the intellectual property that the companies own. So many of the potential genetic variants that could contribute to response, the companies don't own that IP, so they can't include it in their study. So I think there will be a future for pharmacogenomics. It's just not prime time now. And then I see there's another question I'd like to address. The question is, what is the state of knowledge on endocrine HPA axis biomarkers and dynamic tests with respect to antidepressant response? Well, it's probably a planted question since I have worked in this area for many years. So first, let me say that these data are confounded by a lack of collection of data in these studies on childhood maltreatment. The number one determinant of HPA axis activity in adulthood is a history of childhood maltreatment. And depending on when that occurred, it can result in either an underactivity or an overactivity. The one thing we know about the HPA axis in depression is that if you have a persistently elevated HPA axis, you're less likely to respond to antidepressants and also to psychotherapy. But there aren't, other than the CRH binding protein receptor variant that I mentioned, there's very little data that speaks one way or another as to whether HPA axis components can predict antidepressant response. So I think that answers that question. I don't see any other questions, and I guess we'll probably run out of time. So
Well, there is one
Dr.
more.
Smirnova, you want to see the well, it's not all about size, you know. So yes,
there is another question in the chat.
Oh, okay. There's my biggest trout ever. So you could see that. And I'll go back to the chat now. Sorry. Okay. Well, that's a great question. So it's about long COVID and onset of depression. So we have a paper just submitted to the American Journal of Psychiatry coming out of the APA work group on the characteristics of long COVID, the psychiatric manifestations of long COVID, of which anxiety and depression is clearly extraordinarily important component, because anxiety and depression are the two, in addition to cognitive dysfunction, the largest set of symptoms post-COVID. There are no adequately controlled, randomized controlled trials yet of long COVID, but we're certainly looking forward to that. So stay tuned. You'll see that paper come out soon, characterizing the psychiatric manifestations of long COVID. But I can't speak to treatment at this time.
Okay, so we don't have any other questions. Daria.
Yes, dear Professor Kostas Fountoulakis, thank you very much, Professor Charles Nemerov. Thank you for your memory. Of course, we're also interested about your mustache. We can't recognize you in Russia, but I remember the full halls at WPA meetings when people crowded listening to your lectures, sitting on the floor and being near the doors. So it was a great pleasure to listen to your lecture. Many thanks.
And I hope I get to see all three of you at a meeting in the near future, maybe at the APA in New Orleans or the next CINP meeting. But it's good to see all of you. It's been too long.
Yes, indeed. Thank you very much. It would be great, okay. Really. It's a dream. Thank you.
Thank you.
Thank you. And now it's my honor and a pleasure to move to our next great prominent speaker. Everyone knows Professor Konstantinos Fountoulakis, who is our inspiring leader and also the author of this unique project, Meet the Expert. Professor Konstantinos Fountoulakis received his medical degree and doctorate in psychiatry at the Aristotle University of Thessaloniki. And now Professor Konstantinos Fountoulakis is the chair of the Third Department of Psychiatry Medical School, Aristotle University of Thessaloniki, and active leader of the World Psychiatric Association, being in the board of the WPA and the representative of the zone South Europe here. Also actively working with many professional organizations, associations such as European Psychiatric Association, European College of Neuropsychopharmacology, and of course as today's topic is devoted to the guidelines of International College of Neuropsychopharmacology. Professor Fountoulakis is an active leader and expert of this, representing this association. Professor Konstantinos Fountoulakis leads the program of Master of Sciences in Clinical Mental Health, which is also a unique initiative. Professor Konstantinos Fountoulakis published many research papers, more than 400, with more than 15,000 citations, and more than 250 papers have been published in high peer-reviewed journals such as Lancet, British Medical Journal, American Journal of Psychiatry, Journal of Affective Disorders. And Professor Konstantinos Fountoulakis is a member of editorial boards of many important peer-reviewed journals and editor-in-chief of the journal titled, and also General Psychiatry. Also, Professor Konstantinos Fountoulakis has received numerous awards, among them 2012 Triplet Medal of the University of Munich, and 2015 Excellence in Education Award of the World Federation of Societies of Biological Psychiatry. Professor Konstantinos Fountoulakis also has been working in Geneva and now leading a number of multi-center international research and many of projects, and also focusing on the theory of conspiracism in the context of current pandemic. There are actually many things we can say about Professor Konstantinos Fountoulakis, but it's a great pleasure now to listen to the lecture on precision and personalized psychiatry and guidelines of the college, International College of Neuropsychopharmacology. The floor is yours, Professor Konstantinos Fountoulakis. Thank you.
Thank you, Daria. Just a small correction. I'm not chair of the third department of psychiatry, but the rest is more or less okay. So in following the talk by Professor Nemerov, I will focus on the bipolar disorder as an example of precision and personalized psychiatry. We call it the 3P with Stephen Stahl. Precision and personalized psychiatry. It's a dream. It's a target. It's a task, but it's not reality still. So what we need is to first be able to chart the landscape, to know where we are. Medicine in general started with these primitive pre-scientific concepts with wizards, with the shamans. Then it went on to unsystematized medicine. This was the medicine a few decades ago, and still is in many areas of our field. We are moving towards the evidence-based medicine, but in a very slow pace, at a very slow pace, because evidence-based is extremely expensive and very difficult. And if someday we will be able to have a fully evidence-based medicine, then we will go on to the next step, which is precision medicine, and probably then to some kind of individualized from the large groups, which are highly heterogeneous, to smaller, more homogeneous groups, and eventually to single persons, single patients, which is probably not a feasible task, at least not in the way we conceive science today, because the basic property and the basic method of science as we exert it today is to reduce concepts to smaller and simpler ideas and concepts, which means that you need to study groups and carry the knowledge from these groups, the observations for these groups to other groups and persons. So you carry knowledge from a person to person. So if you go and achieve an absolutely individualized approach, then you cannot carry this knowledge to another person, which is a very tricky philosophical question. But still, we need to be more to be able to tailor treatment to the needs of our patients. Now, personalized and precision medicine was in the mind of Hippocrates, Claude Bernard, and Archibald Garrod. But it was not until recently that we were able to achieve some kind of individualized approach. And this was done mainly because we were able to introduce some kind of laboratory testing in medicine, but not in psychiatry still. Now, here we need to contrast the tradition of individualized approach we have in psychiatry because of psychoanalysis and the personalized and precision medicine which follows the absolutely scientific example. These are quite different examples. Now, the evidence-based medicine uses the conscientious, explicit, and judicious consideration of all data and tries to integrate this data with the clinical practice and the data from the examination of the patient. It needs the integration of external data into our everyday clinical practice. Personalized medicine versus common practice has some advantages, but also has some disadvantages, some problems. Now, it's popular, pays more attention to the individual, it's proactive, it makes specific recommendations, maybe it has better outcome, better performance, but it seems that it narrows the options. It is rather difficult to tackle some rare diseases and rare conditions. The knowledge of your vulnerabilities could be a problem, and there is some kind of protection, issues of protection of personal data. The reimbursement policies also are an open question for the legislation, as Professor Nemerov discussed. So in psychiatry, that we don't have any laboratory testing available with high reliability and validity, the personalized medicine is an open question. Can we achieve any kind of personalized approach? You can see here the three major disorders in psychiatry and how our knowledge is currently. We know there is a huge genetic component, but we don't know exactly how it works. We know that some neurotransmitters are implicated, but we don't know exactly what's their role, and probably they are not at the core pathophysiology of the disorder. We know also some kind of biological markers could be of help, but not really, not much of help for the everyday clinical practice. We know that stress could play a role, especially in unipolar depression, but not in the other disorders. So in general, we do have some knowledge, but this knowledge is far from specific and detailed to be able to assist us in our everyday clinical practice and to the individual patient. Now, the problem here is that when you have that psychiatry does not have a single laboratory testing, and in this sense, it is almost a century behind neurology. Neurology obtained its first biological marker, that is the electroencephalogram, in 1922, I think. So we are 100 years behind neurology. And when such a testing appears, then we have a shift in the paradigm. Such a shift happened in the 50s with the appearance of the psychopharmacological medication. It really shifted our way of understanding and perceiving mental disorders, but still, this is not something that it can be of use in the very precise dealing and treatment of our patients. So where are we in terms of treatment of mental disorders and in terms of understanding mental disorder? Are we dealing with an art or a science? What exactly is that we are dealing with? Is evidence-based psychiatry a need that we can achieve and we can pursue? Is it an oxymoron? Because many scholars suggest that mental disorders cannot be framed within the frame of hard science. So this means we are dealing with an utopic wish. Psychiatry is probably in this area between the unsystematized medicine and in the evidence-based medicine, but most of medicine is somewhere here, even surgery is somewhere here, because as said, evidence-based medicine is not old, is a very new, only a few decades old approach. It is very expensive and it goes slow. So psychiatry is where most of medicine stands, but a little bit behind. The basic issues in evidence-based psychiatry is that we need placebo-controlled trials. It's absolutely necessary because we do not have objective outcomes. We do not have blood glucose levels as endocrinologists have with diabetic patients. We need blind trials because this lack of objective outcomes makes bias very strong, and also as a sequence of a result of all these problems is that the primary outcome is what counts. As Professor Nemerov described, a lot of papers are based on secondary outcomes. Now, secondary outcomes are useless when you deal with evidence-based psychiatry because there are too many and their report is selective. So I select those secondary outcomes that are significant and I present them. So this is a deliberate bias. On the contrary, the primary outcome, which is predetermined, is something that can be used as a gold standard for the reporting of data. So these are the very, very strict rules for the evidence-based psychiatry: the placebo, the blindness, and the primary outcome. In 2015, we joined a work group from the CINP. You see the participants here. I was very happy to be part of this team to work on the guidelines for bipolar disorder in a very specific and absolutely strict evidence-based approach. We did a number of meetings. Some of them were very, very stressful because the complexity of the data was too much. The complexity of the disorder was large, and the complexity of the classification, the complexity of the clinical picture as we conceptualized it. The bipolar disorder is much more complex in comparison to unipolar depression or schizophrenia, with affective components, with a psychotic component, with a cognitive component, with a lot of concomitant disorder like alcohol and substance abuse, anxiety disorders, eating disorders, also higher general medical comorbidity, something like twice in comparison to the general population, 2 times fold. One of the most debilitating mental disorders. And the first thing we did was to make a list of symptoms and, more importantly, to make a list of conditions. But I will talk about this later. we did a Prisma flowchart. At the left of the slide, you can see the Prisma flowchart for the randomized controlled trials, and at the right of the slide, you can see the flowchart for the treatment guidelines, the existent to that time point guidelines. We rated these randomized controlled trials in terms of how many whether were positive, negative, or failed. And we had the primary outcome scenarios for each of treatment modalities, for each medication. So we had the primary and the post hoc scenarios, and we developed a grading system of 32 scenaria. And then we graded this scenario in terms of their strength. Eventually, to cut a long story short, we arrived at a 5-level grading system for efficacy and a 3-level system for tolerability. And when we joined these two systems, we arrived at a 5-level method for recommendation for each agent on the basis of randomized controlled trial. Remember, placebo, blindness, primary outcome. These are the 3 principles to judge a randomized controlled trial and to arrive at a recommendation level for the specific medication. And then as you can see here, we created a large spreadsheet. The first column concerns the medication, and the first row concerns clinical questions and states, as you can see here. And we rated each of these agents on the basis of recommendation score. The next thing we tried to do was to identify those clinical states that could be supported, their treatment could be supported by hard data. We did this list, we created this list of facets of bipolar disorder, and with red, you can see those facets that they do have hard data to support their treatment strategy. You can see that 2/3 of these states and facets do not have any hard data. So treatment of patients with these problems is based on your clinical experience and on anecdotal or low quality data. The best we can do for our bipolar patients in terms of precision medicine is to pinpoint the clinical state and then try to see where treatment converges. For example, if we have a psychotic patient in an acute manic episode with psychotic features and a history of rapid cycling, you can see that we have only 3 options. These are aripiprazole, olanzapine, and quetiapine. And you can see that at best, the level is 3. Now, level 1 is the first level of recommendation. Level 3 is somewhat medium level of recommendation. We also developed a less detailed approach because the large spreadsheet needs a very laborious approach and inspection of the chart in order to make your treatment planning. But this chart here is much more easy to apply. The first step for all cases, for rapid cycling, no rapid cycling, with psychotic, not psychotic, mixed features. And if the first step fails, then we go to the second step. And as we go to the 4th step, you can see that we have less specific options. The specific options concern the 1st and the 2nd step. As we go to the 3rd and 4th and 5th, the options become more generic. This is acute mania. This is acute bipolar depressive episode. You can see again that we have this kind of of development from more specific at the early stages to more generic at the late steps, like this. And this is the maintenance phase, the same picture again. I am not going to bother you with specific data and treatment approaches. I just want to show you how the landscape of the data evolves. And then we went on for a much simpler guideline, which gives very, very crude guidelines for the first step, the second step, and the third step for the acute manic and mixed episodes. Very easy to follow, still evidence-based, but less precise, less individualized. This is for acute bipolar depression, and this is for the maintenance. So you can see that you can have a level-based approach to how much accurate and how much precise approach you need to have on your treatment decision. The more precise design you want, the more laborious and difficult will be for you. And there is a ceiling. You cannot go beyond these few facets you saw with the red color in the specific slide I showed you. So there is a limit, which is not very impressive, and it is too laborious. So what we needed to do was to devise, of course, everything is published, so you can go and see the details. What we tried was to develop a software that would give you the precise treatment option for the precise clinical picture of the patient that you enter. And it works for both for Android and iOS, and also for PCs. It's very easy. It's free to download from the CINP website and from the data stores. Here are. This is the interface. The software returns those treatment options with the highest level of treatment recommendation, and very importantly, those options which are not recommended. This is maybe the most important feature of the algorithm. One can choose to see next levels of recommendation with less robust data support. Again, the buttons at the right side of the screen explain what different levels stand for in terms of strength of recommendation. Let's go back to the home screen menu and try a different example. Let's suppose we have a patient at an acute manic episode and we want to choose an agent which is also efficacious during the maintenance phase. Let's go back again to the home screen. It is important that the application give us the ability to plan, having in mind the long-term treatment of the patient. Let's suppose we have a patient at an acute depressive episode, and we want to choose an agent which is also efficacious during the maintenance phase. We choose depressive as the index episode. We can see in the info button what index episode stands for. It is the last acute episode before maintenance. Now let's suppose that the history of our patient suggests he has the tendency to relapse into depressive episodes with very rare manic episodes. This stands for a depressive predominant polarity, and in this case our main objective should be to prevent depressive episodes from emerging. So we tick the relevant boxes.
So now we have asked the application to provide us with the treatment options which are efficacious both during the acute depressive phase and also during the maintenance period and prevent the emergence of new depressive episodes. You can see how narrow are our choices and how specific are the recommendations.
I will be happy to answer any questions.
Thank you very much, dear Professor Konstantinos Fountoulakis. It's very interesting and very important application. And are you going to upgrade this application, perhaps with the top study and elaborating the scale of adverse events of psychopharmacotherapy? It might contribute to the next version and upgrade of this.
I would say it's very difficult because at that time we had this motivation to start with something new, but it took us 3 or 4 years to develop this software, and if we are to upgrade it, we will need to work again for at least a year, and nobody has that much time or that much energy. And of course, the most difficult thing is to explain to informatics people how exactly these algorithms should be developed. This was a very laborious task, and I'm not sure I would like to go again through this. I would strongly recommend everybody to download. It's for free, as I said, to download these applications, especially for training reasons. You can also have fun with your superiors, with your senior teachers, when you you tell them that what they recommend is not evidence-based. But again, I think it's a valuable education tool and training tool more than a clinical tool. Still, what I do is that I check whether my patient has undergone one of these evidence-based treatments, because a lot of our patients are quasi-resistant. They have not gone through evidence-based treatments. This is why they are resistant. They are not truly resistant. Some of them have not received adequate treatment ever.
Thank you very much for your answer. And there is a question, yes, from Sergei Potanin.
What's the clinical experience with oxcarbazepine and topiramate? Topiramate has 5 negative trials, so it's not recommended for the treatment of any facet of bipolar disorder, unless you want your patient to lose weight. So topiramate is out. Oxcarbazepine has doubtful data. You can use it when you have no other option, but the data are of very low quality. You can go to the Apple Store or to the Android Store, Google Store, whatever they are called, and type CINP bipolar guidelines. You will find the application, or you can go to the CINP webpage, and under the guideline button, you can download these applications.
Okay, and for now, no more questions. And Professor Afzal Javed, unmute your microphone, please.
Okay, thank you very much. Thank you very much, Professor Fountoulakis. And of course, it was a great evening. My just one sort of question. What do you think what is the future in terms of laboratory testing, genetic testing, for making the clinicians more empowered to treat these disorders? What is the future?
Okay, my favorite non-mental disorder is diabetes. Why is diabetes? Because type 2 diabetes is treated with a variety of uh, treatment options, including diet, which is a behavioral modification. It can be treated also with insulin when it's more severe and not responsive to more mild interventions. It has probably a genetic component which is probably so multifactorial that we don't know exactly what it is. And also, it is the outcome of environmental and behavioral consequences like gaining weight and insulin resistance. So you eat a lot, you gain weight, you develop insulin resistance, and you get diabetes type 2. So diabetes type 2 for me is a very good model for what mental disorder could be. Now, if we are talking about such a model of for mental disorder, which lies at the um, interplay between genetics and environmental insults, and also uh, life history in terms of choices and behaviors, long-term behaviors. At the end of the day, you need some kind of vulnerability, genetic type of vulnerability, because all of us eat, but not all of us develop diabetes mellitus. Probably these genetic vulnerabilities are of the type of hundreds or thousands of small mutations. Uh, you you cannot have a biological a specific biological marker if you have this kind of disorders. And probably it would be very difficult to have a single and very precise treatment, at least not for the immediate or medium term future. Um, it's called polygenic risk score. It's based on hundreds of genes interacting with very diverse behaviors. You don't know where to start and where to finish with these things. I am more optimistic concerning not pharmacodynamics, but pharmacokinetics. Maybe, but in a small minority of patients. I have seen patients with 100 milligrams of haloperidol not having the slightest extrapyramidal sign, but it's a small minority. To be honest, I don't see anything. What I see, and this is something we need to be very careful of. What I see is that a lot of refractory patients will be proved to be something else, something like virus infection, something like autoimmune disorders, like neurology faces such a threat with multiple sclerosis, which is probably an infectious disease. And if multiple sclerosis is an infectious disease, then neurology will lose it from its nosology sooner or later. So imagine that in the near future, we will be obliged to treat refractory schizophrenia with corticosteroids, with medication for autoimmune disorders, and we will lose much of it the way we lost dementia. We lost dementia because we have abandoned neurological examination. So this is a real threat for psychiatry, and when it happens, it will happen abruptly. So my my prediction is that my opinion is that we need to medicalize the training to be ready for such developments, because they will they will come, and they will cut like the slices of a salami, you know. They will cut off pieces of our nosology if we were not able uh, to cope with the demands new treatments will have. If we are psychotherapists, psychotherapy has reached its uh, top efficacy. It's highly unlikely we will have psychotherapies with better outcome. Okay, we need psychotherapy, but that's all. And also, we will not have better antidopaminergic antipsychotics. That's all we have from antipsychotics. Antidepressants based on serotonin and norepinephrine, they're not going to be better antidepressants of this kind. But probably we will have a decomposition, a fragmentation of nosology, a complete change in the landscape in the next few decades. As said, multiple sclerosis shows, and dementia shows what's going to happen.
So, Professor Fountoulakis, let's keep and hope for the best.
Hope for the best. Prepare for the worst and hope for the best.
Hope for the best.
But still,
Daria,
we can
it's
think about testing systems, and if we really develop these banks of biomaterials, and if we proceed with pharmacogenomics, pharmacogenetics research, maybe we will have testing systems at least to be more selective regarding this or that antidepressant treatment, for example, based on this cytochromes. And
you know, Professor Nemerov was very mild in his critique of existing
yes, I remember,
biological data banks. They are useless. They are useless for two reasons. One reason is what Professor Nemerov said, and to make it more simple, phenotyping is crude. Diagnosis is crude. Diagnosis is lousy. It's not good. It's lousy. So this is one problem. The second problem is that the gathering of data in these data banks and the gathering of material in these data banks corresponds to classic biological theories. You're not going to have a new biological theory by utilizing these biological banks. Probably the audit would be very difficult.
Yes, and much noise from large-scale data as well. Yes, and actually, the problem can be solved only on another level of development. In order to solve the problem, we need to proceed to another level of development of the science. Yes, I understand. Thank you very much. Dear Professor Fountoulakis. Are you talking to us?
No, I think probably he just wants to say thank you.
No. Give me a second. I will, because a lot of people are trying to find the app and they cannot locate it. I will post it, the Android link now in Zoom, in chat. Sorry.
Perfect. Thank you very much. Yes, because there are many questions.
Okay, this is the Android
how to download
link, and I'll try to find the Apple. The Apple is always more difficult to find. Still, you can search the CINP site. Here it is, both of them from the CINP site.
Thank
There
you
is a
very
problem
much.
with Apple Store. I cannot connect to the Apple Store, but still the CINP site contains both guidelines.
Thank you very much, dear Professor Kostas Fountoulakis. And as we understand, we will have the lecture of Professor Guy Goodwin in April, because we didn't want to have it pre-recorded and to save this interactive format of the meeting. So, and we have also full March. So we expect our audience in March and April for the next media expert sessions. Thank you very much to our great speakers, Professor Charles Nemerov and Professor Kostas Fountoulakis, and to Professor Afzal Javed, the President of the World Psychiatric Association, our constant support. And thank you to all the guests and colleagues. It was a very interesting topic today. So see you next time. Bye-bye.
Take care. Bye-bye.